Hello and welcome to another emergency questions and answers for families in ICU and intensive care at home. I'm your host. My name is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com. We will be going for the next hour roughly, and you can ask your questions in the chat pad, or you can talk to me directly here on StreamYard and on YouTube if you follow the StreamYard link that I'm just posting into the chat pad, and you can connect with me directly here, and you can talk to me. You can go on camera, you can stay, without a camera, whatever works for you. But so that is all good. So now, and I also want to welcome our viewers on replay, because I know we get quite a few viewers on replay every time, and I want to welcome them as well and want to thank them too. So yeah, thank you so much. Now, and if you like what I'm doing here, if you like my videos, give the videos a like, subscribe to my YouTube channel, share the video with your friends and families, and leave your comments. Now, before we go into today's questions, what makes me qualified to talk about today's topic, or what makes me qualified to answer questions for families in intensive care? Once again, my name is Patrick Hutzel, and I'm a critical care nurse, and I have worked in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years in intensive care. And I've been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com. And I can very, very confidently say that we have saved many lives with our consulting and advocacy. And you can verify that on our testimonial section at intensivecarehotline.com. And you can verify that at intensive care. And you can verify it in our intensivecarehotline.com podcast section at intensivecarehotline.com where we have done client interviews. So, and with intensive care at home, we have also saved many lives by taking patients out of the intensive care environment, by continuing care and treatment at home, instead of having those patients being in intensive care long term. And also, we've been in business with intensive care at home since 2012, and we are operating all around Australia, in all major capital cities and in all regional and rural areas. Now, with intensive care at home, we are sending our critical care nurses into the home for predominantly long-term ventilated adults and children with tracheostomies, but also for home BiPAP, home CPAP ventilation without tracheostomy, for tracheostomy care without ventilation. Also, home TPN, home IV potassium infusion, home IV and magnesium infusion. We do Hickman's line management, central line management, PICC line management, as well as portacath management. We're also doing ventilation and tracheostomy weaning at home. And we're also providing palliative care at home. I'm the founder and managing director of intensive care at home as well. We're also providing level 2 and level 3 NDA support coordination for intensive care at home as well. Now, let's go to our first question today, which comes from Christopher. And Christopher says, "Hi, Patrick. My mother is 82 years of age and she's in ICU at Sharp Memorial Hospital. They may try to extubate her today. She passed a 2-hour breathing trial. She passed a 2-hour spontaneous breathing trial yesterday, but is very slow to wake up. Also, her blood pressure is not stable after they stopped sedation. What do I do if there's a problem at extubation time?" From Christopher. Well, Christopher, that's a great question, and thank you so much for writing in. Now, Christopher, first thing, if she, quote unquote, only passed a spontaneous breathing trial for 2 hours, I don't think she's ready for extubation, right? I argue that someone needs to breathe spontaneously for at least 24 hours in one go before they can be extubated, safely, I should say, right? Also, if she's not fully awake yet, that's also concerning, right? So what are the criteria for safe extubation? The criteria is breathing spontaneously, passing the spontaneous breathing trials, ideally connecting your mom to a T-piece, basically a spontaneous breathing trial on CPAP pressure support on the ventilator, passing a spontaneous breathing trial on the T-piece, being fully awake, able to follow commands such as squeezing hands, poking out tongue, wiggling toes when asked. Other questions that, other things that need to happen is a very good, strong, spontaneous cough, almost to the point where your mum can cough out the breathing tube herself. That would be a very good sign. All sedation needs to be off. Ideally, opiates are off, or at least minimized to the bare bones. One main side effect of opiates is diminished spontaneous breathing drive, respiratory drive, right? So respiratory depression is one of the side effects of opiates, and they need to be stopped, So next, you're saying that her blood pressure is not stable after they stopped sedation. Ideally, hemodynamic stability is also given. There can be some exceptions around that, but ideally, your mum would be hemodynamically stable. Next, arterial blood gases need to be within normal limits in a spontaneous breathing trial, i.e. PO2, oxygen PO2 is normal, and PCO2 is normal, and pH is normal, right? Next, if, God forbid, your mom is struggling to be extubated, once she's extubated, BiPAP or CPAP can be used, or an airvo can be used, right? Other things that are to be considered in a situation like that is airway swelling, right? Is there some airway swelling? And that can be checked before extubation by letting the breathing tubes cuff down and to see whether there's a leak. If there's a leak, that's actually a good sign. If there's no leak, that means there could be airway swelling, which could make extubation very risky, right? Imagine you're extubating whilst airway swelling. That means the airway could collapse. And that means your mom couldn't breathe. And that means she would need an emergency tracheostomy, which has a lot of risks, right? Also, her breathing rate needs to be normal before she's extubated. So a normal breathing rate means some sort of between 10 to 30 breaths per minute on the ventilator, on pressure support, or on PEEP, right, on CPAP. And the tidal volumes need to be adequate. So what do I mean by that? Tidal volumes being adequate means they need to be 7 to 10 mils per kilo, roughly. So for simplicity, if your mom is 70 kilos times 10 mils, she needs to breathe roughly 700 mils. So I think that, that answers your question here, Christopher, right? But also after extubation, another important aspect of extubation is to do physical therapy and get her out of bed, do breathing exercises, coughing exercises, but get her out of bed. Get her out of bed, mobilize her as quickly as possible so that the lungs can expand. If the lungs don't expand after extubation, there's a risk of a pneumonia, there's a risk of reintubation, right? So, that is really, really important that your mom can breathe well when she's extubated. It's also critically important that patients, or that the window for extubation is chosen wisely. There's a window for extubation, and that needs to be chosen wisely. And also extubation should not happen at 2 a.m. in the morning. It should ideally happen at during daylight hours, sort of between the hours of 8 a.m. to 6 p.m., maybe 8 p.m. at the latest, but at the very latest, the risk of an extubation going wrong after hours is much higher than extubation going wrong during daylight hours, right? Also, what's very important, before your mom is extubated, feeds should be stopped either via the nasogastric tube or via the orogastric tube. Now, next. So that wraps up Christopher's question. Now, if you have any questions, type them into the chat pad or talk to me directly here. Click on the StreamYard link that I just posted in the StreamYard link in the chat pad. You can click on that link and talk to me directly here. Now, let's move on to the next question. But like I said, if you have any questions, you can talk to me live on the show here. I don't bite. I welcome you sending you questions so that I can help you. I'm here to help you, you know. So just give me 1 second until I can read out the next question that has come in from next question has come in from Lisette, and Lisette says, "Hi Patrick, I have a question. My husband is 61. He's on a ventilator with lung cancer, and he's got pleural effusions. Bile continues coming out of his body. What will the treatment be like once he's home, i.e. lifestyle, diet, treatment, etc.? Any tips and advice?" From Lisette. Lisette, I'm very sorry to hear about your husband's situation. Now, Lisette, if your husband has lung cancer and he's got pleural effusions, I would hope they've put in a chest drain to drain those pleural effusions, right? If he's got bile coming out of his body, I don't know what you're referring to. Is he having is he having bile coming out of his stomach? Does he have ascites around his tummy? Are they putting in a drain around the tummy? You know, the very first thing that needs to happen here, Lisette, is they need to take control of the pleural effusions, because once they've taken control of the pleural effusions, that's when they can actually move towards weaning him off the ventilator. So here's the issue with pleural effusions. Pleural effusions is basically fluid accumulation on the body or around the lungs, right? It's often a result of low albumin levels, right? Because if there's low albumin levels, fluids are being pushed out of the system, right? Out of the vascular system, and that's when pleural effusions happen. Now, next, once that's under control, they need to replace albumin. And then look at what are you referring to with bile coming out of his body. You know, I would think you're referring to bile coming out of his stomach. You know, maybe it's coming through the nasogastric tube, maybe he's got a PEG tube. The other thing that you haven't mentioned is your husband ventilated via breathing tube or via tracheostomy, right? That is also a very important consideration here, if he's ventilated via tracheostomy or via breathing tube, right? If he's ventilated with a breathing tube, it is going to be important to keep working towards an extubation. If he's ventilated via tracheostomy, it's also important to keep working towards tracheostomy and ventilation weaning. But the first thing that needs to happen here is weaning him off the ventilator. Now, in terms of what does his lifestyle look like, diet, treatment, outside of intensive care, I couldn't tell you at the moment, because my area of expertise is intensive care. And, you know, my goal is to help you to get your husband out of intensive care. Now, what I can help you with is if your husband is going home, for example, with a tracheostomy, right? But that, I'm here to avoid that with you. You know, that would be the goal here. If a patient is going home after intensive care stay without a tracheostomy, without ventilation, going home is mobile, it's outside of my area of expertise, right? If that makes sense. So, but coming back to your question, you know, you're also wanting to know what are treatment options. Okay, your husband has lung cancer, so what treatment is he getting? Is he getting chemotherapy? Is he getting radiotherapy? Does he need a lung resection? Has an oncologist talked to you? Right? You know, has an oncologist talked to you? What are treatment options? Right? How are they treating? How are they treating the lung cancer? And how are they treating the pleural effusion, right? How much is coming out, right? That is the question here. How much is coming out? You know, is it pouring out? Is it minimal? You know, also, if fluids are coming out, is his ventilation improving, right? So here's what happens when it comes to pleural effusions. Let's just say before a pleural effusion, someone's breathing 12 breaths a minute with volumes of 500 mils per breath, right? And now all of a sudden you've got this pleural effusion, and now your volumes are diminished because the lungs are no longer compliant, they are resisting, right? Common sense. If there's fluids around the lungs, they can't expand to the degree they were able to expand before the pleural effusion, right? Very simple, very simple, right? So that is what needs to happen there. So I hope that answers your question. But, you know, with bile coming out of his body, I have another thought here. You know, that means he probably isn't absorbing nutrition. If there's bile coming out of his nasogastric tube or orogastric tube or PEG tube, that means he's not absorbing nutrition, right? So that means he needs another form of nutrition. Obviously, he's ventilated, he can't eat or drink, but can he have nasogastric tube feeds, orogastric tube feeds, or PEG feeds, right? The reality is he can't at the moment if there's bile coming out, which means he probably needs TPN. What is TPN? TPN stands for total parenteral nutrition, right? Total parenteral nutrition. And with total parenteral nutrition, he needs a PICC line or a central line, but that would be the replacement of nutrition. Once again, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. And they don't know how to manage doctors and nurses in intensive care. That is what most families are up against when they have a loved one critically ill in intensive care, right? So that is really what you are up against at the moment. You don't know what you don't know, right? You really don't know what you don't know, right? And if you don't know what you don't know, you have a very hard time making the right decisions, even asking the right questions. You know, even asking the right questions. So, coming back to, I hope that answers that question, Lisette. Now, coming back to our first question today, where I answered the question whether Christopher's mum could be extubated. So here's a follow-on question from that. I was at the hospital. Hi, Patrick. I was at the hospital this morning, and my mother completed another 2-hour breathing trial. The respiratory therapist said she looks good, but they couldn't get a blood gas yet. However, she's very weak, possibly more so on her left side. The doctor has ordered a CAT scan for today. That might delay the extubation until later today, but the nurse said she still anticipates they will go forward with extubation today. Now, Christopher, I would be very, very hesitant to agree to an extubation when she's still only passing 2 hours on a spontaneous breathing trial. Her extubation will be doomed to fail. Her extubation will be doomed to fail if she's only passing 2 hours of spontaneous breathing trials. Now, here is another red flag. They couldn't get a blood gas yet. Well, they have to do a blood gas. They have to do a blood gas. Now, but here is another concern, right? Obviously, if they want to take her to a CAT scan today, and that may delay the extubation, that is actually a concern too, because if she was extubated and she's going for a CAT scan, she might need to lie flat. She might decompensate. I've seen that a number of times, so she might decompensate, pushing her right back into intubation again. You don't want that. You don't want that. But I don't think she's ready. And I tell you another concern that I have here, Christopher. The other concern that I have is if they are wanting to extubate her, even though she's only passing a 2-hour spontaneous breathing trial, I'm concerned that they want to set her up for a one-way extubation. Now, I do know that your mother has sustained a stroke, right? And I am extremely concerned that they want to set her up for a one-way extubation. I haven't talked about it on this call. I've made videos about one-way extubation. That's almost like a sink or swim approach. And it means that your mother is either going to thrive while she's extubated, and if she's not going to thrive, they won't intubate her, and that means she's going to die. Maybe not immediately, but she'll end up with an aspiration pneumonia. And if she's not intubated again, it'll kill her. Right? Once again, choosing the window of opportunity when to extubate is absolutely critical, and you don't want to get that wrong. You don't want to get the timing of extubation wrong. Right? And telling you that they couldn't get a blood gas to verify, how effective her ventilation is not good enough. It is not good enough. Right? It is absolutely not good enough. So, once again, you need to know what you're looking for. And similar to Lisette's email, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. So, you have to know what needs to happen when someone is being extubated. It has to be safe. Now, there's follow-on emails from Christopher here where he says, "Hi Patrick, I believe they're doing a CT scan with contrast of her brain. The concern is her weakness when following commands." Yes, that is an absolute concern. If she can't follow commands, she's at high risk of being reintubated. Because, for example, if you ask your mom, "Hey, give me a cough," which, you know, she needs to cough once she's extubated to protect her airway, right? That would be a massive concern. So now you're verifying of what I was concerned about to begin with. One doctor a few days ago had mentioned a concern about vasculitis as a result of the meningitis, but they mentioned it again. I think they want clarity on why she is so weak, whether it is the lingering effect of sedation. I do know she's off sedation now, but I think she was put back on Presidex late yesterday when she was awakening and became anxious and tried to, and he puts in quote, breathe over the ventilator. She had propofol and fentanyl over the weekend and was pretty much out of it all weekend. Giving Presidex for someone that should be extubated is a contraindication. It's detrimental to what needs to be achieved. It is very detrimental, right? So giving Presidex is it's counteracting weaning someone off a ventilator, right? Absolutely counteracting weaning your mum off the ventilator. She needs to be completely off sedation. Very simple. She needs to be completely off sedation, right? So, you know, I think they're setting your mum up for failure here, and you wouldn't want that. You wouldn't want your mum being set up for failure. You want your mum being worked up for extubation so she can be extubated successfully. So, switch off Presidex. That is one of the steps that needs to happen. Switch off Presidex, right? Get her to do some deep breathing exercises. Get her some physical therapy, also very important, right? Nothing's happening without physical therapy, right? Get her out of bed, right? You may not think that's possible, but I can tell you from my extensive experience that it is possible to mobilize a patient like your mom, right? And that should absolutely happen here. And that would be one way to get your mom off the ventilator and the breathing tube. So think about this, Christopher. If you're lying in bed for days and weeks on ends and you're not even ventilated, maybe you've just got a bad cold or whatever, you're at home lying in bed, you know, with a bad cold, you wouldn't be as fit to breathe as if you're mobilizing, right? So it's the same for a patient in ICU. There are numerous studies that confirm that early mobilization will help with earlier extubation. Numerous studies have been done around that, right? So the same is applicable for your mom in this situation. She needs to be able to mobilize, right? Very, very simple. Always use common sense. Always use common sense. Is it common sense to give your mom sedation, i.e. Presidex, if they want to extubate her? That is not common sense, Christopher. That is not common sense. Does it make sense to extubate your mom if she's not mobilized properly, if she's not awake yet? Why is she not awake? Well, A, she's getting sedation. B, she's not being mobilized, right? Always use common sense. And this is my advice here. Whatever situation you're facing in intensive care, always bring it back to common sense. If you don't think it's common sense, you're probably right. Trust your gut and your instinct. It'll never lead you astray. Never. Right? It'll never lead you astray. Trust your gut and your instinct and use common sense. Always use common sense. Right? Okay. If you have a question, type them into the chat pad, or if you want to talk to me directly, click on the StreamYard link. I'm sure you have questions if you're here on this call. If not, I will carry on with the questions that have come in during the week. This is a member that we work with, and she had a question. She says, it's from Maria, who says, "Hi Patrick, I was in the hospital last night. The nurse was speaking to me that my mom has to have more pain medications and to let her die. She was to the point of being able to have a speaking tracheostomy fitting. She was communicating with us at the last family meeting with the ICU team only 2 days ago. On that day, they put a fentanyl patch on her without our knowledge. From there, she went into a basically non-communicative mode, looking into the sky without blinking and closing her eyes. From what it seems, there is no return from here. I love how they emphasized about me believing in miracles, which I do, but whatever." The nurse says it's 55 days now for my mom, and it's done. To just let her go because she will never get better. I don't know what to do. Well, I think you do know what to do, Maria, because you're already pointing it out. So if 2 days ago she was awake and she was talking, and now they're knocking her out with fentanyl, they're trying to create the quote-unquote doom and gloom narrative. They're trying to create an end-of-life care narrative, right, that you need to counteract. Next, you as the decision maker needs to approve whether she can have fentanyl or not. Fentanyl obviously knocked her out completely, right? And that's not acceptable, right? So just because someone has been in intensive care for 55 days doesn't mean that, that's it, that's the end of it. Now, for context, for you guys watching this here today, Maria's mom has a long-standing medical history, and I'll just, read out the medical history for context. She has a history of non-alcoholic liver cirrhosis, portal vein thrombosis, gastric varices, gastroesophageal reflux disease, hypertension, hypothyroidism, and a gastric adenocarcinoma treated in 2015. She's had multiple hospital admissions for worsening liver function and hepatic encephalopathy. She was admitted last month with severe circulatory shock and multi-organ dysfunction syndrome due to a large left thigh hematoma. She was treated with fluids and packed red blood cells, and her anticoagulation therapy was stopped. Her hemodynamics subsequently improved. While in the intensive care unit, she underwent a liver transplant workup and was initially qualified. She was transferred to the ward on March 7th. Now, John Paluska, welcome to the call, John. You're asking, how many times have you seen miracles in your career? Sometimes, and I can tell you what I actually understand under miracles. I remember looking after a patient in ICU a few years ago. He had a stroke. He would have been in his late 70s or early 80s. He was, very, very sick. Was on multiple forms of life support for many weeks. Was in an induced coma. Ended up with a tracheostomy, and he probably even had a cardiac arrest at some point. He got resuscitated, and he was on the brink of death for weeks. But we didn't give up, and the family wasn't going to give up, and miraculously he came out of ICU a few weeks later. And that was certainly one of the miracles that I saw. There was another miracle that I remember. There was a patient in his late 80s or early 90s who had cardiac surgery, and I remember he had a cardiac arrest during surgery, and I think also in ICU. It's touch and go. And bear in mind, this man was in his late 80s or early 90s, and he got out of ICU alive eventually, but again, not after many battles that we fought. And I remember him coming back into the ICU maybe 6-8 months later and thanking everyone and saying, look, you've saved my life, I'm still going. Like I said, he would have been in his late 80s, early 90s. That was certainly a miracle. But John, here is another thing that I've seen as well, and I'll probably come back to another quote-unquote miracle that I've seen over the years. I've seen patients survive ICU that shouldn't have survived ICU, right? When you looked at the diagnosis, when you looked at what's going on at the time, you know, you thought you wouldn't have put a cent on that patient's recovery, right? And they did survive. And then I've seen other situations where a patient was literally ready to go to a hospital ward. You know, they were meant to have their last night in ICU. They were ready to be discharged to the ward the next day, and everything seemed to be working perfectly for this patient. And then all of a sudden, they have a cardiac arrest overnight and they died. I've seen that too. Now, I wouldn't put that in the miracle category, of course, but what I want to illustrate with that is the unpredictability of life in general. You know, it's the unpredictability of human nature. You know, I do believe that humans are very resilient, way more resilient than intensive care teams want to make you believe. Right? We as humans are very resilient, but I've seen the other, you know, and I've seen young people that you thought, you know, would come out of ICU in no time, and they didn't. You know, it's very unpredictable. Life is unpredictable, unfortunately, you know, or fortunately, whichever way you want to look at it, right? I do remember another, what I would put in the category of miracle. I remember that was my first ICU that I worked in way back when. And we were looking after a young man there. He fell off a roof, working on a roof, whatever, had a nasty, nasty head injury and other fractures. And he would have been in ICU also for months on end. And he was touch and go. And, you know, we thought he would never survive. You know, his life was hanging at a thread. And you know, he was on, again, multiple forms of life support, including dialysis. And eventually, I remember he survived. And I also remember he came back to the ICU maybe a year later and just thanking everyone and saying, look, you know, look at me. I don't remember a single thing, but look at me. I know my life was hanging at a thread. And all of you people here, you know, helped save my life. And I'm still standing. And I'm so grateful to be here. You know, that was also a miracle in my eyes. And there would have been others that I don't remember. You know, John, you know, I think I can confidently say I've looked after thousands of critically ill patients and their families over the years. There would also be, if you go to our intensivecarehotline.com, your questions answered section or blog section, you know, you would also see some quote unquote miracle stories. You would, you know, where, you know, we helped clients to save their loved ones' lives with our advocacy, right? Where ICU teams would have said to the families, oh, you know, your loved one's going to die. And even if they do survive, they won't have any quality of life, right? So there would be some success stories there. You know, whether you want to put it down as a miracle or whether you want to put it down just as common sense to wanting to save someone's life, you know, I'm not even sure anymore. You know, I just think it's common sense to want to save someone's life. You know, I don't even see it as a miracle. I see it as a duty for us as health professionals to save someone's life if that's what they want. And most people want that. Now, John, you're saying my wife and mother of our 3-year-old had a PE, pulmonary embolus, and 50 minutes of CPR, given 8 units of blood from Lucas trauma. 2 weeks later, she walked out of the hospital. All in the hospital said it was a miracle. It sounds like a miracle, John. It sounds like a miracle. Because that's amazing. That is amazing. thank you for sharing. Thank you for sharing. 50 minutes of CPR must have been a very effective CPR. And probably, I don't know whether the CPR was in the hospital or outside of hospital. Unfortunately, 5 days later, she had a seizure and now in a coma with DAI. Coma with DAI. So you're looking for a second miracle. DAI. What is DAI? I've never heard of DAI, but I'm just looking it up. Oh, diffuse and axonal injury. Right, okay. Right. Yeah, no, you are looking for a second miracle for sure. What challenges is your wife facing right now, John? What questions do you have right now? Diffuse and axonic injury. Yeah, no, I got that. So what challenges are you facing right now? What do you think is your biggest challenge? Long road ahead. Yeah. Yep. Probably a long road ahead. Yeah. What's your biggest challenge there, John, at the moment? What do you think is your biggest challenge? What is it that you need help with? Anyway, where do I think about what long-term care facilities? Why would you? Okay. I tell you what I think about long-term facilities or long-term care facilities. I presume you are in the US. Long-term care. What's in the word long-term care? Well, in the word long-term care is long-term care. Why would anyone in their right mind go down the track of long-term care? Right? And maybe that is the only option for your wife. I don't know. Right? But why don't you look at short-term care? Why don't you look at how can I improve my wife's situation as quickly as possible? Right? She's beaten the odds once before. Why can't she beat the odds again? Many leading facilities, how do we pick? Well, at the moment, is your wife having a tracheostomy? Tell me more about your wife's situation. Look, it might be easiest if you just come on a call here and we talk. That's how I can help you the quickest. You can just use the StreamYard link that I'm just posting in the chat pad, and you can talk to me directly. Talk to me. What do you need help with? But what do you need to do? One question is, okay, what long-term care facilities? Well, here's another question for you. And I don't understand enough about your wife's situation yet. What about avoiding long-term care facilities and getting her on a path to recovery as quickly as possible? Right? What about that? Maybe change the way you look at things. When you change the way you look at things, the things you look at change. Right? Oh, there's John.
Me?
Hey, John. Can you hear me?
Yeah, I can hear you. Can you hear me?
I can hear you. That's great. That's
Yeah,
great. Thanks for joining.
We're driving here, but I found you. I mean, certainly we saw a miracle, and we're still digesting the miracle. When my wife had a pulmonary embolism, she was at home and had somebody come over and check on her, and called 911, and she was still unconscious, and then they had a Lucas the piston-based CPR machine that they hooked up to her when she started coding. So it was, immediate CPR care, and it did take 50 minutes to stabilize her. And the trauma from the Lucas machine, which is highly effective in pumping the heart, also caused a hematoma, and there was lots of blood loss, and at that early days and moments we didn't know anything about her brain, and shortly learned after that she had um, a small stroke, but the brain was relatively healthy. And around day 5, the sedative uh, was kind of lowered, and she woke up over the period of a day and a half. It was a miracle. Everyone in the hospital, every doctor, maybe a third of the doctors said, I've only seen one other miracle. This is the second time, but most people said this is the first miracle I've ever seen. And, there was certainly a lot of emotions, going into this, and, coming out of this. And, on her 5th day home, she had a seizure, and while in the car with her mother driving, and mother pulled over, and they did CPR. After they got her into the ambulance, I don't think she coded until she was in the ambulance, and it was about 25 minutes of CPR, and the MRI and EEG results, specifically a diffuse anoxic injury. The response from her is, limited to the point where, we've seen her cry twice. When a certain friend had walked in the room a few nights ago, I was able to get her to stick her tongue out 7 or 8 times. There was anywhere from a 3-second delay to a 15-second delay. And can see when we FaceTime people when she's in her awake state, that her eyes start to focus in, but very much she's still in her own coma, and has been in the hospital just shy of a month now from this second episode. Maybe I'll try to wrap it up here, but in my situation, um, you know and I really appreciate you say short-term care, because that's what we really want to hope on. As the hospital begins doing their discharge, you know someone who is has a peg feeding tube, a trach, but is breathing fully on their own, has a healthy body, fully recovered. Kidneys came back online. The hematoma healed. We're talking now just about the brain injury is. For me, every night I'm the guy that is going to Google, and is reading about miracles, is reading about different types of treatment. Is you know what what am I looking at, and how do I figure out, is it something local with an occupational therapist that can try something? Is it looking at certain brain rehab centers around the country? And this is kind of where I feel very challenged and really lost. So
Yes, yes.
yeah.
Can I ask you a few questions, John? So how long has your wife been in the coma now? How long?
November 27th.
Oh, I see. Okay, so the PE was earlier than
So
that.
the PE was on November 8th, and
Okay,
she came out of a coma after 5 days, released after 2 weeks, um, on the dot, and then 5 days later, on November 27th, she had what has been described as a seizure, was conscious for 5 or 8 minutes, even when the EMTs were there, and then went into cardiac arrest.
I see.
Yep.
I see. And what's been happening since the 27th? Tell me,
Sure.
she's still in an induced coma at the moment?
She is not in a induced coma. They do have 3 types of seizure medications, and the diagnosis of obviously cardiac arrest and epilepsy, and I think some of the meds that they have her on, other than Keppra, might be like 2 of them, may have a sedative factor to it. But other than that, it is on her own. I mean, it's not it's no longer the kind of induced coma that I saw before, where they weaned her off of propofol. She's no longer on that. Sorry for the nav that we have here.
That's okay.
Yep.
Does she have a tracheostomy?
She does. Yep. She does.
Yeah. Okay. Okay. Have you heard of Glasgow Coma Scale?
I might have. Say that again.
Glasgow Coma Scale, or GCS?
Oh yes, yeah, yes. They've. I think they have kind of like verbally assessed her around a 5, because I think at a 6 is when you're like, hey, can you do this? And she's not really following commands at this point. It was a miracle to me, 3 nights ago, to have her stick her tongue out multiple times in a row. So, there's kind of, that to a degree.
Okay. Okay. Is she at a point where she can already have physical therapy, get out of bed?
She has no movement. She can move her chest, but there's no other movement other than that.
Okay. Okay. Right. Do you think that could improve if they were start to getting her out of bed? Do you think it's lack of stimulation to a degree?
It very much could be, and that's what we were talking to the hospitalist about today. Is the talk was that she has not had any occupational or physical therapy, but that she is responding to a degree. So we're just trying to figure out some of that aspect of getting her to a place, I guess, in kind of like the immediate time frame that can get her at least that very initial stimulation.
Exactly. One of the problems in ICU that I have seen, if you're not starting early mobilization, there's often a delay in waking up. There's often a delay in recovery. I would assume your wife is quite young.
Yeah, she's 41.
Right. So, like, not that age should make a difference. It shouldn't. Whether someone is 41 or 81 shouldn't really make a difference how you approach these things. But I do believe the younger person is, the higher the chances for recovery, of course. And are they trying to, quote unquote, sell you on going to a long-term facility? Are they trying to sell you on that?
No, that we just really don't have direction at this point. That's kind of the challenge of there's, I guess, once you step down to another hospital, like a transition hospital, it's kind of on us to figure out where what's the long-term acute care, or it better said from what's kind of the short-term plan. Again, to emphasize, she hasn't had any occupational or physical therapy at this point.
Critically important. The best ICUs that I worked at, John, were the ICUs where you started to mobilize a patient early, right? Where there were no delays.
Yeah.
Right. It always concerns me that when hospitals make excuses, or we can't mobilize someone, whatever the case may be. It always worries me. There needs to be a can-do spirit, a can-do attitude. And I think it's going to be critically important in your wife's case. Also, when someone has a brain injury, keep in mind something's gone wrong with the brain, and the neurons need to connect.
Sure.
And the neurons are only going to connect again, if ever, by stimulating the mind. And mobilization is the first step to that. Are there any other things happening? Does she have seizures? I think you mentioned
So
that.
so she had seizures, myoclonic seizures the first 2 days, but the EEG studies have consistently shown since, kind of the initial episode that there are no longer any seizures.
Okay, that's good. That's also positive. That's also positive.
Yep.
She's not on dialysis.
Nope. She was did one dialysis appointment at home, and then was very much her body did it herself. I mean, she's
Okay, that's good. That's good. John, I really think with everything that you've shared, one of the main focuses here needs to start rehabilitation early. Mobilization, physical therapy. I do believe that needs to be your focus, and you might need to gently ask for that and push for that. The only reason that stops patients from mobilizing, from my experience, is if someone is unstable. Of course, you can't mobilize them. If someone has fractures waiting for surgery, you can't mobilize. Fair enough. Everything else should not be a hindrance to mobilization.
Yeah.
Right? And it'll give you a much quicker idea where this is heading if they start mobilizing her. It'll give you a much better idea where this is heading.
Yeah, no, I mean, that's encouraging, just to kind of have that, emphasis coming from, another source. I mean, again, like it's hard when it's new to you and you don't know how to navigate it. And I, found you through, just kind of, Google, and it's appreciative, you spend your time, focus on, things that in outreach. So, yeah, I mean, any advice that you would give me in this moment, today was a kind of a big push for the occupational and physical therapy at the hospital.
Yeah, no, keep at it, and don't give up on looking for a second miracle. It's no guarantees, but stay positive and keep asking for what you want, and keep asking for what is common sense. I do believe mobilization, even after a critical illness, is common sense. You have to start somewhere, getting the body back on track.
Yeah, no, I mean, 100%.
And keep in mind, John, there's so much research out there every day that someone is not getting mobilized in ICU after a critical illness. The body deconditions rapidly, right? And there's studies that, there's muscle wastage of X number of % every day without mobilization. So the sooner she can mobilize, the quicker you can counteract more deconditioning. Right?
Yep.
John, I do need to wrap this up. I usually, I've been going for an hour now. I do need to wrap this up here because, I've got to get on to the next things that I'm doing.
Sure.
I do need to wrap this up here. You know where I am. If you need help, go to intensivecarehotline.com. You can call me there on one of the numbers on the top of the website, or just follow up with an email at support@intensivecarehotline.com. I do paid consulting and advocacy. We do review medical records, all the rest of it, just in case you need more help. And also, thanks for everyone watching this. Thanks, John, for sharing so generously. And wishing you and your family all the best.
Thank you.
Be safe. Be safe. Thank you so much. Now, for anyone else watching, go to intensivecarehotline.com, where we offer consulting and advocacy for families in intensive care. Go to intensivecareathome.com if you need home care. With Intensive Care at Home, we're operating all around Australia. in all major capital cities, as well as in all regional and rural areas. If you're in the US or in the UK and you want intensive care at home, contact us as well. We can help you there privately. I do need to wrap this up. Click the like button, click the notification bell, subscribe to my YouTube channel if you like these videos, and keep your questions coming so I can make the content that you want. And if you want to cover me a topic on one of those YouTube lives, let me know. And I wish you all the very best and Merry Christmas as well. We will be open around Christmas for intensive care at home and intensive care hotline. Please reach out. Once again, wishing you and your families all the best. Take care for now.